Please give a warm welcome to Marion Boldingh. For presenters view. The next slide. You just press this button to go to the next slide. I want to have presenters view. Oh, is it not in presenter? Let me see. Oh, there we go. Is that better? Should we back up? Maybe. Are we here? Yeah. Okay. Yes. So, thank you. Thank you for having me here. So my name is Marion Boldingh, and I will in the next 20 minutes give you a brief introduction regarding pregnancy in patients with Myasthenia gravis. So I will break it into 5 parts. First, I will start with a case. Then I will say something about pregnancy and the development of MG. Then family planning issues, treatment in pregnancy, effect of MG on the unborn child, and then some concluding remarks. So this is Anna, and Anna is 30 years old. She works in a kindergarten, and she's 24 weeks pregnant with the first child when she first noticed a drooping eyelid, problems breathing for her kids, problems swallowing, and neck weakness. And she also noticed variation during the day. And the diagnosis of MG was confirmed with electromyography and supported by the presence of anti-acetylcholine receptor antibodies. And the symptoms disappeared after administration of pyridostigmine. And no MRI or CT scan was taken because of pregnancy. So the diagnosis in pregnancy is based on these typical symptoms: elevated levels of antibodies, and neurophysiological testing such as decremental response on EMG or increased jitter on single fiber EMG. And none of these tests are contraindicated in pregnancy. So pictures for thymoma and operation can wait until after birth. So she was first treated with pyridostigmine only, but she had an exacerbation in the 31st week, and she improved on IVIG medication. But a second and more severe exacerbation came in the 36th week, provoked by a pneumonia. And she was treated with antibiotics and another IVIG treatment, but no improvement. And prednisolone was started in low doses, and she was referred to our hospital, which had a neonatal care unit. And in general, it is advised that women with MG give birth in hospital with expertise on both MG and perinatal care. And she was checked by a midwife at the hospital, and we had a meeting with the obstetrician and with the pediatrician. And she was exhausted and had problems breathing and talking. And because she did not improve on her second IVIG infusion, she got a cesarean and on maternal indication. And this was performed under regional spinal anesthesia without incident, and a boy was born with good APGAR scores. An antibody to acetylcholine receptor was present, but a treatment with pyridostigmine was not necessary because of only minimal symptoms of neonatal MG. So after birth, she was in the obstetric post-anesthesia care unit, and the maternal signs were good, but after a few days she got troubles breathing, and the oxygen saturation levels dropped into 70 and 80s, and she reported shortness of breath and stated, "I can't breathe," and she needed BPAP. It was help with a mask, and neostigmine, that is pyridostigmine intravenous, was added if necessary. But still, she didn't recover, and plasmapheresis was started. And she was intubated after 3 days. And we added the max doses of prednisolone. And then she recovered quickly. And after the 5th day with plasmapheresis, she was extubated and discharged to the department. And the postpartum period was not a honeymoon. She had problems with breastfeeding, probably due to stress, and we decided on formula. And she suffered of PTSD and a postpartum depression afterwards. And the dad did stay home for 6 months to take care of the baby. And she was on sick leave for the same period. And we started rituximab, and thymectomy was planned. So in this present case, the diagnosis was made during pregnancy. And pregnancy is a well-known risk factor for clinical onset of MG, or exacerbation of MG. And we know from studies that 30% of women with MG experience worsening during pregnancy, or in the period after birth. And there are multiple case reports of onset during pregnancy. However, until a few years ago, there were no case control studies. We also know that from animal studies that estrogen increases the antibody production in MG. So a few years ago, we wondered whether this peak of onset, as you can see, between 20 and 29, if that was coincidental or if there was a real relationship between with pregnancy. So we decided to design a case control study to prove whether this relationship was coincidental or not. So we designed a study using a participant from a questionnaire study from 2 different countries, and we included women with onset of MG between 15 and 45 years of age. And we defined the outcome as onset of MG between 9 months pregnancy or 0 to 6 months after birth. And 11.5 of the Dutch women had onset in pregnancy or after birth, or 18 from the Norwegian women. And we compared them to the expected distribution in the general population and found that there was an increased risk of onset after birth, but not in pregnancy. So this figure illustrates when in pregnancy the risk is highest. And as you can see, the risk is highest 0 to 3 months after birth compared to other periods in pregnancy. And the risk is highest among mothers who give birth for the first time compared to mothers who have given birth before. Another interesting finding was that the disease occurred earlier among Dutch women than among Norwegian women, as this figure shows. And the length of breastfeeding did also differ. So Dutch women stops earlier than Norwegian women do. And the 2 lines illustrate that. And we found that 35% of the variation onset was due to breastfeeding, indicating a delay by breastfeeding. So we hypothesized that the decline in breastfeeding possibly was related to maternity leave, because the maternity leave in Norway is longer than in the Netherlands. In the Netherlands they have 3 months, and in Norway they have 9 months. So this can be an example how political regulation can influence the distribution of this disease. So 3 years later, Anna comes back to the office, and she has now a well-controlled MG. She has been thymectomized, and the pathology showed follicular hyperplasia. She uses rituximab, prednisolone, and pyridostigmine, and she wants a sibling for a boy, but wonders whether it is safe. But her partner do not want another pregnancy because he is worried. And here are questions Anna and her partner have. They wonder, what are the personal risks? What are the risks to the unborn child? What about the disease? What about the treatment? And it is very important to make a treatment plan together with the obstetrician and together with the GP. And females with MG, they do worry about the disease having negative consequences for their children. And there are several studies focusing on this, among others these 2 studies from Germany, which tells us that as many as 50% of MG women abstained from having children, and between 7 and 21% delayed starting a family. And the most common reason was worries for drug effects on the unborn child. And this reminds us that repeated and clear counseling with the neurologist is necessary. So what kind of information can we give them? We know that the risk of abortion is not increased in MG women. We know that the risk of fertility is not decreased. We know that stable MG gives little risk of exacerbation during pregnancy. However, the course during pregnancy can be unpredictable. So 1/3 might worsen, and the course in postpartum period too. So it might be a good idea to reduce risk as much as possible. And we know which medications are safe and unsafe. And we know that thymectomy before pregnancy gives a better outcome for mother and child. So this study from Norway shows that thymectomy before delivery in MG women gives a better outcome for the baby, with a lower risk for neonatal MG. And there's also a lower risk for complications during delivery. And as you can see from this table, most women benefit from being seen by a neurologist during pregnancy to minimize the risk and to select the best delivery mode in collaboration with the obstetrician. And which medication is safe? Pyridostigmine is a drug that is safe during conception and during pregnancy because it does not cross the placenta. Rituximab can be used until 3 months pre-conception, and the risk of giving it later has shown to increase the risk for infection in mother and child. The table highlights that corticosteroids in low doses and azathioprine is regarded as safe and can be continued during pregnancy and breastfeeding. And many recommend 20 milligrams a day as a maximum dose. And high doses can give diabetes and hypertension. You don't want this in pregnancy. So, and there's also a discussion about that it can give other pregnancy complications. That's the reason why you should try to keep the doses low. Celsep, mycophenolate, methotrexate, and cyclophosphamide should be avoided. And when needed, treatment with IVIG and plasma exchange are recommended as rescue therapy during pregnancy and in the postpartum period. Eculizumab has been studied in pregnancy and other diseases with little risk on the unborn child, but we have not enough data to recommend it yet. But it might in the future be a drug which can be used. And this new medication, such as complement inhibitors and FcRn blockers, have limited data to support safety in pregnancy and are currently not recommended in this period. But this efgartigimod, which I've been told about before, that inhibits recycling of all types of IgG antibody and can inhibit IgG transport from mother to child, and therefore it may become a treatment alternative during the first 2/3 of pregnancy to avoid a complication called fetal acetylcholine inactivation syndrome and arthrogryposis in the child. I'll come back to this later. So what kind of risk do we have during pregnancy? There are some older study from Norway, which says that the perinatal mortality is increased in MG women compared to mortality in the general population. And MG deliveries are also more complicated with an increased risk of cesareans, increased risk of membrane ruptures, and increased risk of interventions. And there is also an increased risk of getting other autoimmune diseases during pregnancies. However, this was a study from 2003, and the numbers are changing. And this is a study from 2020, with more than 1,000 MG pregnancies included. And this study shows that compared to other pregnancy, there are no differences in adverse outcomes, except for slightly higher numbers of diabetes that is possibly related to corticosteroids. And they did find longer hospital stays and a higher risk of respiratory failure among MG women. They did find a slightly risk of C-sections, but this was not significant. So that the numbers are changing is very important to get out to the patients, that it is actually not a large or not a very, very risky to get pregnant. I think it's very important to inform them that they should not avoid pregnancy because of the risk factors. The study confirmed preterm birth, but beside that, the child of the MG women appears healthy with rarely intrauterine deaths or congenital abnormalities. So to sum up in one figure, there is an increased risk of preterm births and maybe an increased risk of membrane ruptures. You may have worsening of MG, but this can be handled with IVIG or plasma freezer or intensified immunosuppression. Vaginal delivery is preferred. Some doctors or some women prefer sections, but the reason for this should be prolonged labor or exhausted mother. In case of preeclampsia, one should be careful with magnesium because it can trigger MG crisis, and levetiracetam should be used instead. And as you have understood, MG women should give birth in hospitals where they have access to intensive care and neonatal care. So that brings us to the next question. What kind of effects does MG have on the unborn child? And autoimmune disease mechanisms and treatment and genetic factors could all have an impact on the child. So what kind of advice can we give? We have this neonatal MG with muscle weakness that occurs in 4 to 10% of the newborn babies where the mother has MGs, and that is due to transplacental transfer of the antibodies. And it's temporary. It lasts for the time that the mother's IgG antibodies persist. And mothers with one child with neonatal MG have an increased risk of neonatal MG in their future children. And as I showed before, there's an evidence that previous thymectomy reduced the risk. And the common symptoms are hypotonia, ptosis, and problems sucking. And the symptoms are very rare after 4 weeks, and they improve already during the first 1 to 2 weeks. And there is no persistent weakness documented in these babies. And for the most cases, only supportive treatment is needed, such as help with breastfeeding. And first-line treatment can be very low doses of pyridostigmine or neostigmine. And IVIG is very rarely used. So second, mother's antibody can also cause a condition called FARAD, fetal acetylcholine inactivation syndrome, or arthrogryposis with contractures. That's related to restricted movement of the baby in the uterus. This is a very rare complication, about 1%. It's very, very seldom. It's far more serious. Not long time ago, in 2023, an article about this was published in Brain, telling us about the spectre of the disease. And the clinical spectre is very diverse, as you can see from this picture. And these pictures are from this article, and they show a number of conditions that affect the joints, often the face, and sometimes the arms and the legs. And they often have a myopathy. They have problems feeding, scoliosis, and problems breathing. And it's caused by exposure to maternal acetylcholine receptor antibodies directed against the fetal acetylcholine receptor. And in this publication, 50% of the cases had mothers with undiagnosed MG, and they often were siblings. So, more aggressive MG treatment during pregnancy appeared to lessen the severity, but did not prevent the development. And treatment of the mother with MG with immunoglobulins or plasma exchange during pregnancy reduces the risk for persistent damage. And if you know about this, you should thymectomize. And the survivors, the children, can be treated with oral salbutamol. So, and breastfeeding is recommended, and this counts also for mothers with FARA and neonatal MG. And this helps the baby to build a stronger immune system and reduces the risk of the baby for future autoimmune diseases. And for the mother, it stimulates the prolactin production and it modulates the immune system. And the drug transfer to the breast milk is very limited, so there is it's not dangerous to do so. So in the end, there are some guidelines about MG in pregnancy, which can be used. And here are the key recommendations from the Nordic guideline, as we published. And the end of the case, rituximab was tapered off. Azathioprine was tapered off, that was her own wish. She didn't need to. And she was stable during her whole pregnancy, and she gave birth vaginal to a boy with a forceps delivery. She had no worsening postpartum, and she gives breastfeeding. And everything went better off the second time, and she's now very happy. There's a boy for her. Boy for a boy. Their second child. So that was the end of the case and the end of my story. Thank you.
All right, people, you know the drill. We already have a question. Wonderful.
Marion, thank you very much. It's very interesting. Do you know if we have any statistics on the MG worsening after giving birth when you are done breastfeeding? Do you know any statistics on that?
It's very unpredictable. So you cannot say, actually. I think if you are unstable, it might be that you... I think they say 1/3, actually, can worsen, 1/3 do not worsen, and 1/3 is change. But it's very unpredictable. In one pregnancy you might worsen, in one pregnancy you might not. So you cannot tell the patient, actually. But you should plan this pregnancy in a stable period. I think that's the message. And you should not plan it first 2 years after diagnosis, maybe. You should try to do it when they have settled a little bit.
Okay, thank you.
Okay, so I think the question that Liselotte was trying to ask was after stopping breastfeeding, like the hormone drop after stopping breastfeeding, if that affects worsening of MG.
No, what I showed in the figure, I think that was rather protective. and that breastfeeding just stabilizes the immune system.
Yeah.
That was the reason, actually, so that it sort of delayed the onset.
Yeah.
So I don't think I think prolactin acts as a protective hormone.
Exactly. Yes. I had a question about because in the slide with you had rituximab and you had to stop 3 months before getting pregnant if you're planning it. But there were no figures on rituximab in breastfeeding. And I know that it might be because of lack of research, but there is...
You can give it, you can have rituximab in breastfeeding.
Yeah.
Only 20% of rituximab is going over to the milk, so it's no, it doesn't harm the baby.
And I know that the baby's digestive system usually breaks it down. So yeah, I just wanted to get it out there.
Yeah.
I have a question. Is the risk of neonatal MG different when the mother is in remission compared to having an active MG?
It's a good question. Maybe Niels can answer.
The risk of neonatal MG while the mother is in remission compared to when the MG is active.
The risk of neonatal MG if the mother was immunosuppressed? Was that your question? No.
No, if the mother is in remission and don't have any symptoms of MG.
No, I think it's no correlation between mother's severity of mother's disease and the transient neonatal myasthenia in the child. So also females without any symptoms can have children with a transient weakness, and mothers with severe myasthenia can have completely healthy children. The explanation is probably that the receptors in the child during fetal life and very early, they are a little bit different from the adult receptors, so that the antibodies can bind more strongly to the child's receptors than to the mother's receptors, and vice versa. The receptors are not identical in the mother and the child.
Yeah, a comment, Marion. Thank you. So there has been one more publication, actually, from this year. A PhD student of mine, Laura O'Connor, has published in European Journal of Neurology a big Swedish study. So I just wanted to reassure a little bit also that we looked into 443 Swedish women during 20 years and compared to more than 4,000 healthy women in Sweden. We didn't see any increased risk at all for MG women. There was an increased risk of not having a spontaneous delivery, but that was probably because it was planned for many of them. But also the children were not smaller, and we didn't see, so that was a really reassuring study, just to have a little bit on actually not to be too afraid of pregnancy with MG. Yeah.
No more questions from the room, it seems. Well, in that case, I would like to warmly thank you, Marion, and not just you for this excellent presentation, but also the women that shared their stories with you so that you could share them with us. That was such a wonderful personal touch. Thank you so much, and let's give a warm applause to Marion.